Okay, مساء الخير. I am recording the last part of RA for section 4 لحتى ما يصير turbulence بتوزيع المحاضرات وكل sections يكونوا going together. I am recording this for you. It will be available on Teams for everybody. وإذا في أي comments, points not clear لطلاب section 4, we can discuss it next week إن شاء الله بما أنه صار تعليق للدوام اليوم والتغت محاضرات 8 صباحا. So last time we stopped by the biologics, and we said that we have two groups of biologics, the anti-TNF biologics and the non-anti-TNF biologics. وحكينا عن anti-TNF biologics where they can be indicated, their precautions, contraindications, their types. Today we'll talk about the non-anti-TNF biologics, and then we'll talk about the algorithm of treatment. The first drug in the group is abatacept. احنا حكينا انه in autoimmune disease like RA, many immune cells are involved, including T lymphocytes, B lymphocytes. They are overactivated and they start to maybe release antibodies in case of B cells, or themselves attack the tissue, the joint, like the cytotoxic T lymphocyte, the CD8, and both can actually release inflammatory mediators like interleukins, TNF, and so on. Collectively, this all will contribute to the inflammation we see in the joint side and cause all the symptoms and the pain and the swelling associated with RA. So if we look at the activation of T cells, now regularly to activate the T cell, we need interaction between T cells and antigen-presenting cells. After that interaction, usually the T cell is activated and start to proliferate. هلا هذا الinteraction takes place through two molecules, CD80, 86 on antigen-presenting cells. It will bind CD28, the receptor on the T cell. As a result, the T cell is activated. Now, when we talk about autoimmune disease, we want to stop the activation of T cells to control the immune response. And so we do not want this interaction to proceed. A drug like abatacept is basically, it will bind to the CD80, 86, a glycoprotein on antigen-presenting cells. And by binding to it, it will block or stop the interaction between antigen-presenting cells and CD28. In other words, if we give abatacept, the T cell cannot be activated and then cannot proliferate, cannot attack the tissue. So we produce immunosuppressive activity. So basically, the drug is an inhibitor of CD80, CD86 receptors on antigen-presenting cells, and it will stop or prevent T cell activation, proliferation, and so the immune attack on the joints. And it's usually indicated in the moderate to severe disease. It's not among the drugs or biologics that are indicated early in the treatment. Generally, we start with a TNF inhibitor in general. Can be given as IV infusion, available also for subacute infection, could be given alone, or usually, as we said, for most biologics, it's always better to combine biologics with methotrexate particularly. You get a better response, even though some biologics can be given as monotherapy. يعني بعض الbiologics ممكن ينعطوا as monotherapy. However, it is better always to combine them with methotrexate. And sometimes you don't have a choice. You must combine with methotrexate, like, for example, infliximab, for example, an anti-TNF inhibitor. Or, for example, rituximab, again, a chimeric antibody, and it's better to be combined with methotrexate. We will discuss it next. So this is about the dynamic of abatacept. The side effect profile, all in all, is okay. However, because it's highly immunosuppressive, there is increased risk of infections, like urinary tract infections, respiratory tract infections. Patients are considered immunosuppressed, and so they have to be very careful about contacting sick people or acquiring infections, and they have to report carefully any sign of infection, even the very mild signs. يعني هذا المريض إذا بصير معه sore throat, إذا بصير معه mild grade fever, they have to report it immediately because their immune system is inhibited. The immune system cannot fight the infection and it can actually deteriorate. يصير معهم huge complications. فبالتالي the patient is immunocompromised, at risk of infections. Also, blood pressure might increase. The drug might cause hypertension. Patients must be monitored for blood pressure. Another non-TNF biologic is a drug called rituximab. This is a very important drug when we talk about lymphoma management, so we will discuss it in great details in lymphoma. However, rituximab is a chimeric monoclonal antibody. The target here is CD20 molecules on B cells. احنا قلنا إنه B cells are also involved in the autoimmune attack or response in RA, so they are a target as well. CD20 is a very specific service marker to B cells. You will not find CD20 on other immune cells. فهو a very specific target. Rituximab binds CD20, and as a result, there is depletion of B cells and decrease in antigen presentation to T cells. يعني ultimately, you decrease the immune response in this case. It's a non-TNF biologic. It's very good, as we said, as a drug to treat lymphoma. وبالتالي, rituximab might be a very good choice, a very good biologic, if the patient has history of lymphoma or at risk of lymphoma. It's a very good biologic to go for. هلا usually مثل ما حكينا مع الانفليكسيماب, it's good to combine methotrexate with rituximab. Again, in the usual regular doses, we use methotrexate to treat RA. This will decrease the potential immunogenicity of the drug لأنه rituximab is chimeric. It will also improve the treatment outcomes when we combine methotrexate with the biologics, as we said in general. So this is one option in non-TNF biologics. Rituximab, like all biologics, requires the tuberculin skin test. In addition to this, we have to check for latent hepatitis B infection. فبالتالي, before we test or use rituximab, we also need to make sure that the patient does not have a latent hepatitis B infection. We check hepatitis B antigens, certain antigens. In addition, مثل ما حكينا, all biologics to make sure the patient does not have a latent TB infection. Now, other non-TNF biologics, they target interleukins and interleukin receptors. We have two drugs. Tocilizumab, this is a humanized monoclonal antibody. The target here is interleukin-6 receptor. هذا الانتيبودي بيربط معه, it binds to the interleukin-6 receptor, and so inhibit the ability of the receptor to bind to interleukin and activate the inflammatory pathway. Again, could be used as monotherapy or preferred to be combined with methotrexate. ونفس الشيء عادة هاي الأدوية هي يعني يعني severe أو not responding patients more common DMARDs and biologics. Anakinra is an antagonist, is a receptor antagonist. It blocks interleukin-1 receptor. It's not an antibody, it's an antagonist. يعني هو ما له يعني better outcome أو efficacy profile, but it's an option especially for the refractory أو in case of failure to other biologics لمريض RA. فالأناكينرا usually it comes يعني last options available, like the non-biologic DMARDs اللي احنا قلنا عنهم بيكونوا last resort. مثلا الجولد preparations أو الديبنسلامين, cyclophosphamide, cyclosporin. حكينا إنه هدول برغم إنهم non-biologics, they are potentially toxic, but they are not more effective than the first line non-biologics. وقلنا كمان إنه الأناكينرا is one of them. Okay, فالأناكينرا هو a biologic drug. It's an anti-NF biologic. However, it's not commonly indicated unless we have several line failures. يعني أخذنا كتير أدوية وجربنا وما كان في response, then we can think of this as an option. طيب هلا let's talk about the algorithm, how to treat. الapproach بالmanagement دائما سواء when we talk in RA or any other case, you have to handle this as a puzzle. So you need data, بدك معطيات, and you have to know after that where to guide your therapy. Okay, so when we talk about RA, what is the most important piece of data to decide about my drug therapy or treatment? We need to know the severity of the disease or activity of the disease. Okay, so this is the important information we need to know here. According to the disease activity, we can divide the patients with mild disease or low activity and severe or high disease activity. هلا, if we start with a patient, a DMARD naive RA patient with mild disease, and mild disease means the patient does not have any of the signs of highly reactive disease like extra-articular signs. The patient is rheumatoid factor negative, not too many joints involved, يعني symptoms are not very bad. The patient still ما عنده disability, deformity, الX-ray ما في erosions. يعني in all, there is RA by assessment or diagnosis. مثل ما حكينا إنه diagnosis is the statement made by MDs أو الدكتور. يعني إحنا كصيادلة سريريين كفرنديز إحنا بيوصلنا assessment and so we plan the treatment accordingly. فالassessment إذا كان إنه mild, low RA disease activity, then the best option to start with, يعني DMARD naive patient does not exposed to DMARDs before, ما أخذ DMARDs قبل هيك. To start treatment in patient who is DMARD naive and with mild disease or low activity, it's always good to start a non-biologic DMARD. And usually this is one of the 4 options in the first line, اللي هم either methotrexate, sulfasalazine, hydroxychloroquine, or leflunomide. And we said that usually methotrexate is the preferred. بمعنى, I have these 4 options. If there is no contraindication to use methotrexate and methotrexate is available, then start methotrexate. This is the preferred, okay? And we said that DMARDs need time to give effect. So during that bridging time, we need a few weeks. You can add a steroid, like prednisone, and you can also add NSAID. So steroids, NSAIDs are adjunct. They are added to DMARDs. They are not planned to be used as monotherapy. And so this is the initial treatment, and we follow the patient if we are reaching the outcomes we need or not. طيب, هلا, if the patient at the baseline, at the presentation, at the first time, they present with moderate disease, with high disease activity or severe disease, احنا قلنا إنه how to recognize severity, how to recognize if the disease is يعني of high activity or not. Usually, if the patient has any extra-articular manifestation or sign, any of them, this is considered a disease of high activity. Presence of RF, rheumatoid factors. Okay, إحنا قلنا إنه مش كل مرضى ال RA بيكونوا rheumatoid factor seropositive. قلنا ممكن 60% 70% منهم. Yeah, the RA, the rheumatoid factor is there. بس ممكن 30-40% ما في. The presence of rheumatoid factor indicates يعني highly reactive disease. Okay, it's a bad thing. إنه يكون في عندي deformity at presentation in the bones, in the joints, إنه يكون في erosion, damage على X-ray. All these, any of these actually, mean that the disease is moderate to high activity. And so with more aggressive disease to start with, we need to intensify our regimen or treatment. So we have options here. We have many options here. Option one is combination of DMARDs. Here we mean the non-biologics. احنا قلنا انه the first line non-biologics can be combined. يعني انت ممكن تعطي dual treatment of methotrexate plus any one of the other three choices. You can start methotrexate plus sulfasalazine plus maybe leflunomide or methotrexate plus hydroxychloroquine. And you can go up maybe to 3 drugs in the regimen. So here you can start with a combination, not a monotherapy. Usually monotherapy, a DMARD, a non-biologic DMARD monotherapy might not be enough here. So the first option is a combination of non-biologic first-line DMARDs. Now, pay attention إنه هون إحنا بنحكي or, so this is another option, okay? Option 2 is to start a biologic, okay? Biologics could be TNF inhibitor or non-TNF inhibitor. Now, you can start either one. If we look here at the algorithm, or TNF inhibitor plus minus methotrexate, or option 3 is non-TNF inhibitor or biologic plus minus methotrexate. So you can start either biologic with or without methotrexate. Generally speaking, it's always good to add methotrexate to the biologics, and it's preferred to start TNF inhibitors. However, هدول options. يعني نفترض مثلا إجا المريض عنده multiple sclerosis. Then you cannot start a TNF inhibitor. You will jump, you go to non-TNF biologic. Okay? So it's an option, but in case you can use TNF inhibitors as the biologic, it's preferred to go with that. And it's also very much preferred to add methotrexate to the biologic drug. The fourth option, okay, is tufasitinib plus minus methotrexate. احنا قلنا أن التufasitinib ليش هون بحطوا لوحده؟ لأنه احنا حكينا based on its mechanism of action, it is not a biologic. It's a novel drug. It's a Janus kinase inhibitor, but it does not classify as a biologic. فإذا احنا هون عنا 4 different options, okay? In case the patient at presentation has moderate to high disease activity, severe disease, then you have 4 different options to go for, okay? The preferred is maybe to use or try first a combination of non-biologic DMARDs, or maybe to start with methotrexate plus a TNF inhibitor. يعني عادة you start one of these, but the other 2 options are available, are there, you can go with these. هلا المرضى اللي بياخذوا البيولوجيكس at the first therapy، يعني أعطينا إحنا biologic، أوكي، وبعدين صار عنا disease progression أو we did not reach our target or there is a failure of therapy، أوكي، ورح نحكي هلا عن failure. What can we do? Keep in mind that you cannot combine biologic drugs. You cannot, in the same time, concomitantly, you cannot make the patient use 2 biologics. يعني أنا ما بقدر أعطي المريض مثلا abatacept, an anti-TNF inhibitor, plus etanercept, a TNF inhibitor. You cannot combine 2 non-TNF inhibitors or combine 2 TNF inhibitors. We do not combine biologics because the patient is severely immunocompromised and the risk of infections is very, very high. فبالتالي, if we have a biologic drug in the regimen and there is failure, احنا قلنا عادة البيولوجيكس بيكون معهم الدواء الثاني هو methotrexate. ففي حالة الfailure to this kind of regimen, what can we do? We can change from one biologic to the other. So we can switch, okay? We switch from one drug in the biologic group to the other. How we can switch? If you start here with a TNF inhibitor, okay? You can switch to either another TNF inhibitor. يعني, let's suppose that you started infliximab, okay? You did not reach your target. Can you switch to etanercept, another TNF inhibitor? Yes, you can. So failure of one TNF inhibitor does not preclude the use of others. You can try other TNF inhibitors. طيب what if in the very beginning من البداية أنا ماني عاطي الميثوتريكسات مع الإتانرسبت مثلا، أوكي؟ أو ماني عاطي الميثوتريكسات مع الأباتاسبت مثلا. Can I add methotrexate in case of failure or I did not reach the target? Yes, you can. Okay, so we are modifying based on the first line treatment اللي احنا عطيناها للمريض. So here, if you are using a single TNF, you can add methotrexate, same thing here, or just to switch the biologic. احنا حكينا عادة يفضل دائما انه انا ما اعطي البيولوجيك لحاله، فيفضل انه دائما من البداية يكون الميثوترexate موجود مع البيولوجيك. فبهاي الحالة إذا بصير failure مثل ما قلت بنغير يا إما to another TNF biologic, or we can just skip TNF inhibitors and go to a non-TNF inhibitor, أو الأوبشن الثالث إني أروح على التوفاسيتينب. أوكي؟ فالتغيير هون بيكون يعني حسب إحنا من البداية شو أعطينا. أوكي؟ So you switch to a non-TNF biologic plus minus methotrexate. It's always recommended to have methotrexate or another TNF inhibitor. طيب إذا بهاي المرحلة كان عندي moderate to high activity and no response, you can also keep trying, keep changing. يعني إذا جربت أنا أكثر من TNF inhibitor, I can try another non-TNF inhibitor, or هون ممكن أعطي توفاسيتينب. أوكي للمريض plus methotrexate. The opposite here is right. فإذا أنا عم بعطي non-TNF inhibitor, I can try another non-TNF inhibitor or TNF inhibitor مع الميثوترexate أو التوفاسيتينب. Okay, so here, after trying non-TNF inhibitors, you can go to a TNF inhibitor أو التوفاسيتينب with methotrexate. So it depends on what we have been using to start with. The rule that usually methotrexate is always there with biologics, recommended to go there, and not to combine biologics in the same treatment. Switch from one biologic to the other, or maybe use tofacitinib after you try more than one biologic drug, and still we are not reaching our target. يعني when we tell that we have treatment failure, أنت بعتبر إنه ما في failure, okay? On average, if you try your regimen and if you escalate the doses, or if you adjust the administration for parenteral drugs, you decrease the time between doses, for example, for 6 months وما كان عندي response, هون بعتبر إنه عندي failure, okay? I need to switch, I need to change my regimen. Okay, فبالتالي if this happened, we have to interfere with the drug therapy ونغير البيولوجيك مثلا. Okay, therapeutic outcomes كيف بدي أعرف إنه I'm reaching my target؟ كتير مهم إنه the symptoms, the clinical picture improves with time. يعني دائما إحنا بنحكي إنه اللاب findings مهمة, but it should go side by side with the clinical picture. فإذا المريض كان عنده to start with at baseline عنده severe pain, swelling, stiffness مثلا, cannot actually handle things, or في some sort of difficulty in the function, we assume if we are using the right treatment يعني successfully, then the symptoms should improve. Okay, يعني المفروض يقل stiffness, يقل acute attacks, swelling, يتحسن الهاندلنج أو function of the extremities and so on. هلا lab findings important. We can check ESR, we can check C-reactive protein, which we expect to be high in the beginning, rheumatoid factors, يعني other potential findings بالمرضى، وإذا الأشياء is يعني عم تتحسن then we are reaching our target. اوكي فاحنا عندنا الاشياء مع بعض بتمشي. ال clinical improvement بال symptoms should go with the improvements in the lab findings together. I assume انه as long as the patient is responding there is no need to change your therapy, just keep your treatment. اوكي فاحنا عادة بنعطي المريض التريتمنت بهمنا two outputs انه am I reaching my therapeutic outcomes or not? If yes, keep things. The second important thing هو tolerability. يعني can the patient tolerate therapy? Sometimes يعني احنا بندخل بالchallenge انه okay, the disease is under control, the symptoms are improving, but there is drug adverse effects that cannot be tolerated by the patient. نفترض إنه أعطيته أنا دواء وعمل له certain toxicity that cannot be prevented or managed. If not tolerated or serious toxicity, again حتى لو في عندي good control over the disease, we might need to change the therapy, okay, or modify therapy in a way. فهاي النقطتين إنه tolerability and achieving therapeutic outcomes are usually we need these to judge if we have to modify, change our therapy or not. So by this احنا we are done بchapter rheumatoid arthritis. The material to be included in exam من chapter الأنيميا والrheumatoid arthritis موجودة على e-learning. Next week إن شاء الله we will start with oncology. رح نبلش blood cancers. We'll start with acute leukemias. If you have anything that you did not understand من اللي أنا حكيته اليوم, please let me know. بالنسبة للقوائم, I hope that you finish التوزيع sometime by next week. We want to assign you topics, so you want to work on it, فبالتالي it might take some time. The earlier the better. That's it for now. Okay. وبشوفكم إن شاء الله الأسبوع الجاي. يعطيكم العافية.